flow regulation, which we looked at in the peripheral vascular chapter with the myogenic mechanism. The same kind of thing happens with coronaries. We'll look at that. We looked at endothelial function in our heart attack class. This will review that. I won't hit that too hard. Plaque development, we looked at that with our heart attack class. How does a plaque develop? You all wrote, remember the test? You had to write a paragraph about that. So you've all had that. So I'll review that. O2 consumption in the heart, that's something new for you. We talked a little bit about collateral circulation. So there's some new and some old, as I mentioned before in this class. I'm going to focus on the new, and I wrote the test last week before I left to come on this road trip to Tacoma. So I focused on the new stuff. I didn't really get into like plaque development, vulnerable plaque, and all the steps of all the, the way plaque develops over the years. I didn't really get into that. So it's going to be the new stuff. So you guys can focus on that. So let's go. So this is something for you guys in echo and vascular. The coronary arteries go down over the heart like the veins on your hand, and they run down the grooves between the ventricles and the atria. So the here's on the left side of the coronary of the aortic root up in the sinus of Valsalva, on the left coronary cusp is the left main, and it bifurcates after somewhere between 5 millimeters, 10, 15. Some people have short, some people have long left mains. And it bifurcates, and the one that goes anterior is the left anterior descending, and it goes down the anterior interventricular groove. So that's left ventricle. This is right ventricle. And the circ goes down the left atrioventricular groove. So this is left atrium and left ventricle. And then the right coronary artery goes down the right atrioventricular groove, okay? So they're kind of going down in these, they call it a sulcus. Remember sulcus, word from the A&P? It's like a little groove. So they're kind of like running down the little valleys. And along those, also the veins. The veins run along next to them. And then, anyway, so, okay, next. So this is the dotted line shows something that's posterior. The posterior descending is going down the posterior interventricular groove. So this side is LV and this side is RV. The LV is like a fist. When we're going to do a deer heart dissection later today, and you'll see that. And the right ventricle sits on top of the left ventricle, kind of like my hand. The LV pumps like a strong fist, and the RV pumps more like a bellows. So the LV is a pressure pump, and the RV is a volume pump. It only moves at, what's the pressure in the RV? What's the millimeters of mercury in the RV? Thinking about your hemodynamics. The RV has about how many millimeters systolic?
130.
The left is 130 and the right is about 25. So it's just low pressure, pushing through the sponge, the lungs, very low vascular resistance. Okay. But that's how the anatomical structure is. The LV is just like power, and the RV is just kind of more like a bellows. And there we already talked about that. And then together they all form like a halo around your heart. And people have anatomical variation. Sometimes your LAD only goes to maybe this far out to your apex, and the LAD would be along this groove, and it feeds out usually to the apex, and then the PDA is coming along underneath. And where the PDA stops, the LAD stops. Here, the PDA stops way back, and the LAD went clear around the apex. Some people have a LAD that stops here, and then if that's the case, then something has to feed the apex, and the artery that's in that neighborhood will feed it, and that's going to be like the PDA. So you'll see variations. Everybody's arteries look a little different. If you looked at the veins on your hand, everybody has a different pattern. When you guys go to take your CCI RCIS exam next spring, they will do a scan of the veins of your hand with a really high-powered light. They take your fingerprint, they take a photo of you. You have to bring like 2 kinds of government ID, and then they take a vein scan. Wow. So yeah, they don't want Scott taking the test for you. So they want to make sure you are who you say you are. That's one of their protocols. So at any rate, let's see what we got here. So there goes your plan. So this is like a crown, and the LED goes on the anterior wall of the left ventricle, and the PDA goes on the inferior wall, and in between here's the septum, and then the circumflex is over on the left lateral wall, and the right coronary artery, its primary first part of it, the right coronary artery is usually extends and becomes the PDA, and that feeds this RCA, the beginning of it feeds the right ventricle. So the septum is fed from the PDA and the LAD, and then the anterior wall is fed by the LAD, and the lateral wall of the left ventricle is fed by the circ. This question mark has to do with dominance, and that's a term that might be new to the echovascular people, but maybe one of the cath guys can tell us what is dominance. What does that mean?
What part, if it's the left side or the right side that feeds the PDA and or the extension vessels?
That is correct, Morgan. And that is the right answer. So here's a little heart model. And basically it's whatever coronary artery feeds the posterior descending, which is down here, and the LV extension branches, which we'll get into a little bit later. About 60 to 80% of the people, humans, have their right coronary artery dominant. And so this has shows this ring being continuous. Usually that terminates. It doesn't connect there. It terminates. So where the circ ends, these LV extensions continue. And it doesn't really matter if you're left or right dominant, but it's better to be right dominant, because if you lose your left main, then you lose your anterior lateral part of your LV perfusion. And if you're, did I say left dominant? Oh, well, normally, if you were left dominant, then your LAD would feed, your left branch would be feeding LAD, circ, and PDA. And if you lost your left main, you'd lose all perfusion to your left ventricle, and you cannot survive that. If you are right dominant and you lose your left main, you still have the inferior wall of your left ventricle being perfused. You're still not going to survive, but we have a small chance to save you. But if you're left dominant and you lose your left main, nobody can save you. Well, only one deity maybe, but not a person. Whatever deity you worship or not, but you would need some serious help.
What was the brims and points?
The what?
Crown configuration? Brims?
The crown is just like the arteries circumnavigate your heart, and they want to feed all areas. And I think I used the analogy of like a lawn. You might have 8 zones in your yard, and the water pressure is not enough to water the whole yard at one time. So your lawn watering system does one section at a time, but in the end, it does it all. Well, we need to make sure all the lawn gets watered, and it is all done at the same time by the coronary arteries. But we have to cover every bit of myocardial muscle with perfusion, and there's variations on which branches are going to do their share. Zones are different sizes on different people. Okay, so this is just another look at that, and I think we're going to look with this next layers on this slide. We're going to look at these branches that come off these main arteries. So, I'll flow with it. So, see how that's broken there? So, normally people are right dominant. Do you guys have any questions from echo or vascular about this dominance? Most people are right-handed, so you'd say they're right-hand dominant. I'm left-handed, so I'm left-hand dominant. We can both do the same kind of work, and it just doesn't really matter, but there's just variations. I guess here's a little tidbit. I was talking to the researchers at University of Washington, and they had a canine lab. They never advertise these because they don't want to advertise doing research on animals because people don't like it. But they had a dog lab, and the dogs are left dominant. And then other places that had pig labs, pigs are right dominant, like humans. There's some little tidbit about nature. Dogs are left dominant. Okay, here we go. Here's the side branches. Now for you echo and vascular guys, let's add a secondary layer of the coronary arteries. So now we have these things called marginals. They come off of the circ and the right coronary artery. And the obtuse marginals come off the circ, and the acute marginals come off the right. So the obtuse marginals feed the lateral wall, and the acute marginals feed the right ventricle. Okay? And then there's branches that come off of the LAD and PDA, and they feed the septum, the interventricular septum, and they named them, very easy for us to remember, they're the septal branches. Okay, so the septum actually has flow from two directions. And then there's one more set of branches that come off the LAD, and they're called diagonals. And that's as far deep as I'll have you guys go for a coronary anatomy on this unit. But I will expect you to know that. I will ask you questions about that. In the cath prep class, we went farther. We went to the 3rd level, but we'll stop here at the 2nd level for this class. But those are the branches. So if you hear of a doctor, if you're reading a report that says the guy has a 90% obstruction or 90% narrowing of his first obtuse marginal, then you'll know that's on the lateral wall. So if you're doing an echo, you'll be looking on the lateral wall. This is a picture that this is a printout you can make, and you can cut it out and make your own heart model if you want. And that's just, I'm not going to spend, we did that in lab. We spent some time in lab with that. I'm not going to do anything. It says something wrong. I don't even know what that is. I'm not going to spend any time with this one. This slide is really interesting. This is a heart cast model where they take latex and they inject it in the coronaries. And then they put latex into the chambers, and yellow in the circ, white in the LAD, and blue in the right. And then the colors you can see in the left ventricle, right ventricle, pulmonary artery, outflow tract. And then they put the whole heart in a bucket of lye and let it dissolve away, so that the only thing left is the cast of the arteries. Have anybody seen that human? Those what's it called? It's like a museum thing that goes around. There's it's like the wax bodies, and then they peel the layers away. Sometimes they show muscles, sometimes they show nerves. The body exhibit. Yeah, they had that. It travels the world. Sometimes there's some permanent exhibits, but they have kind of things like this, pretty elaborate, various looks at anatomy. This one's really good because it really shows us the coronary arteries. And I'm going to add the next layer so we can see it from both sides. So there's the left main. It's coming off the aortic root. It's kind of hiding, but there you can see the left main. This is a lateral view. And now this is kind of like what we would call like an RAO view, and the apex is on the right. And it's kind of like the echo parasternal long axis view. So this is the anterior wall, this is the apex, this is the diaphragmatic or inferior wall. This would be like the parasternal short axis view, and this would be like an LAO view for us, looking from this way. And so there's the lateral wall. You can see it really well, but you can't see the lateral wall here because it's on the other side. So at any rate, that's the point I was going to make, is this LAO is kind of like a parasternal short axis, and the RAO view is like a parasternal long axis, the walls that we see. So look at this LAD. It goes down the anterior interventricular groove. There's the LV, and there's the RV, and there's that LAD. And see this gap here? That's where the septum used to be, but it dissolved away in the bucket of lye. And though these little guys that dive down in there, what are those guys? Those are the septal perforators. They're perforating into the septum. And these little guys that come off the side here, those are the diagonals. Okay? Now, there's the circumflex, and these branches over here are the marginals, in which there's either acute or obtuse. You cath guys know what they are. The circ gives off obtuse marginals, and the right coronary artery gives off acute marginals, and they feed the right ventricle. Look, here's the RV. As you go around the corner, it splits, and now we've got the PDA, posterior descending. This is a distal branch, and it tells us which one's dominant. This one's right dominant, and these are those left ventricular extension branches we talked about. This is the AV node artery. That's going deeper than I'll ask you guys to know for echo and vascular. But I want you to know the main branches and the secondary. So there's the PDA, and there's the posterior. These are the posterior septal perforators. Questions, comments? That's a really good picture. Shows you how they perfuse.
So
Go ahead.
the septals on the RCA or PDA, they feed the inferior septal wall, right?
Yes. Okay. So these septals feed the bottom half of the septum, and then the LAD septals, they feed the top half of the septum. Yeah, and they kind of come together. Yep. Okay, this is not really an angiogram because it's not embedded, so we won't let that play. It can't play. But there's a picture of the right coronary artery in the RAO projection, and these are also those branches, these acute marginals. We call this a proximal right, mid right, and distal right coronary artery. And then where it splits, then that's the PDA, proximal, mid, and distal posterior descending artery or posterior descending coronary. And this is another model. I'm not going to make you guys know if it's LAO or RAO this time because we did that in the cath class. But here's so you don't need to worry so much about the views for echo and vascular. I already taught the cath guys that. This is a view of the left coronary artery. If it has two main branches, it's probably the left. If it has one main branch, it's probably the right. Okay, and when you look at the left coronary artery, if you see the spine on the picture, the spine's really dark. That's usually where the circumflex is because the spine is posterior and the circumflex is more posterior. The one that's closer to the light, and this is all dark, I give you that on this, the artery that's closer to the light up in the lung field is the LAD. It's the anterior by the lungs and the sternum. We never see the sternum on our angiograms, but sometimes we see the spine. So if you see a branch that has two, it's probably the left. And if you see the spine, the one that's close to the spine is the circ. Make sense? Okay, so that really wasn't in the book. That was like extra stuff that we added on from our angiographic perspectives for you. This is a little anatomy map and some questions. So I guess we can take this little quiz real quick here. This is anterior, that's posterior. And this is going to be left, and this is right. It's like we're looking from above. So where's the tricuspid valve? It's going to be over here. Look, 1, 2, 3. Tri. 1, 2. Bicuspid mitral valve. Tricuspid is the tricuspid valve. Yeah, and they call these. Look at here's another thing. These little pieces on there. Look at these. They're like little parachute puffs. Little puffy stones, those are called scallops. And they call this one A1 for anterior scallop 1, A2, A3, and this is posterior scallop 1, posterior 2, posterior 3. That's when we need to know that when we start getting into doing like mitral clips to catch these leaflets and clip them together if you have mitral regurgitation. So I'm going to clip A1 and A2 together, or I'm going to clip P2 and A2 together, and the doc will plan it out and document it that way. But that's just taking you another layer. These are called scallops. Go ahead.
What are scallops?
Scallops are just like these little, like this little cove here. That little puff there, a little round. That's a scallop. Like the shell of a scallop's kind of round like a shell, seashell. That's a scallop.
So it's part of the leaflet, right?
It's part of the leaflet. Instead of just saying the anterior leaflet, Go ahead.
Yeah, so it's like broken into little zones of
Yeah.
the leaflet.
Yes, we're now saying not just the anterior leaflet mitral valve, but
Zone 1, zone 2, I see.
but anterior scallop 3. So that's more specific on where on the valve
Okay.
when we start wanting to put devices and clip them together and things like that. That's part of one of my talks I'm giving in New Orleans, so that was on my mind. I'll be talking about these scallops there. So I just had to lay that in there for you. That's enough about anatomy. I won't go any deeper, but this is the anterior, most anterior is pulmonary. Obviously, this is the left coronary. There's the left main, left coronary cusp, right coronary cusp, and then that makes this the non-coronary cusp.
So does the right ventricle valve have scallops as well?
The right does too, and it would have scallops as well, yes.
Okay.
Yeah. So I'm not going to go through all these layers. We can do our own little, you already passed anatomy. So now let's do the veins. The veins wrap around the heart and they drain the heart. And most of the cardiac veins go back into the coronary sinus, which drains in the posterior wall into the right atrium. That's mostly, and this is the only organ in your body where the veins drain right back into itself. Because usually like the veins of your kidneys will go back into the vena cava and come back into the right atrium. But the heart, it drains back into itself. Kind of makes sense. It needs to be recirculated out. But that's kind of a different thing. So let's see what we got with all these layers here. They overlay, they run pretty much next to the arteries. Except for these, and so usually, so here's a little thing. These cardiac veins, they all dump into the coronary sinus except for one group of them. These little guys up here that are by these acute marginals on the right, these are called anterior cardiac veins, and they drain directly right back into the right ventricle, which is kind of weird, but that's what they do. So if I say, well, where do the cardiac veins drain? You'd say they all drain into the coronary sinus, except one little group. They just decided to do their own thing, and they just go right into the right ventricle. And that's the anterior ones, the ones that feed. They drain the venous perfusion of the right ventricle. And so now let's break these cardiac veins down and name them. And I want you to know the names of the cardiac veins. We use those in the EP lab because we place lines and we go sneaking. It's dangerous for us to put equipment in your left ventricle and work in the arterial system. There's clot problems there. But if we can do work from your right ventricle and your right atrium, and we want to get over to your left ventricle, what we do is we sneak in the coronary sinus. So here's your arteries. They're the halo crown. And here's the veins. They're also a halo crown. But if I want to do some work over in your left ventricle, like with an EP catheter, like put a pacemaker on inside your left ventricle, I'll slip it into the coronary sinus and go down one of the veins, and I'll pace your ventricle from over there instead of leaving it in an artery at risk of clots. So we do play around in the cardiac veins in the electrophysiology lab. I don't know for you vascular guys or echo guys if you do much with the veins, but there was anyway. So look at these guys. All these veins, the whole crown of it, they all go back to the coronary sinus, except these two little fangs over here. Those little dudes are those anterior guys, and they're just dumping right into the right ventricle. So the one that does the LAD, and in the next slide we'll put this in writing, but then the vein that drains the LAD is called the great cardiac vein. And your LAD is your most important coronary artery, so the great is it's the greatest of all the arteries. It's the most important. In other words, if you lose your LAD, you have a higher % chance of dying. And the second most important coronary artery is your circ, and you have a second chance of dying with circ. The third is your right. So your percentage of chance of survival is lowest if you lose your LAD and highest if you lose your right. Middle with the circ. So PDA is called the middle. And the small arteries over here feed, well, we'll get into watch this here. So they follow the same grooves. Now, all these layers, Wes likes layers. Here we go. So great cardiac vein drains the LAD. And then the middle cardiac vein drains the PDA. And then the small cardiac vein, it drains the right ventricle down over here, and it does go into the coronary sinus. These real proximal ones, we'll get to those. Okay, then there's the posterior cardiac vein. That drains the circumflex and the OMs. Okay, so we'll back up again. The LAD is drained by the great. The PDA is drained by the middle. The distal RCA is drained by the small, and the circ is drained by the posterior. And then the RV, proximal, is drained by the anterior, and those are the ones that don't go in the coronary sinus. So there's 5 cardiac veins, and that's what they're named, and that's what they drain. And I want you to know that. Here's a good picture for you. It shows all of that. So there's the coronary sinus, and there's the great cardiac vein on the anterior wall right here. And then there's the middle cardiac vein, which is the PDA. There's an anterior view and there's a posterior view. So there's a posterior, there's the middle cardiac vein draining the PDA. And then the anteriors for the right and the smalls for the right. And then the posteriors over here for the circ area. Okay. So this is another new picture for you. This is looking at the flow of coronaries down at the subendocardial level. So now what we've got is left ventricular cavity, epicardial surface of the heart. So now we're going to look at the flow right down in the wall of the muscle itself when you go from the surface and dive down into the muscle. So This 4 is an artery. That's an artery, a coronary artery coming in, bringing in bright blood. The arrow shows it's coming in. Most of the time, most of the flow is going to go through the capillaries, feed the muscle, and then go out into a vein, which then this like 5 will head off back to the coronary sinus. Okay, that's the normal flow. But this slide shows us 3 variations. 1, 2, 3. Occasionally, an artery will just sneak right on through, like it's like a little shunt, and that's called, I'm going to pull this up. That's called the arterioluminal artery. And that I don't see those very often, but it would just squirt. It's not good. It's like a shunt. This one I see these occasionally, these number 2, the Bayesian veins. So these are actually doing the work. They perfuse the coronary tissue with capillaries, but then instead of sending the blood back to the coronary sinus, it goes directly into the LV. So occasionally when we do an angiogram, we'll squirt a contrast. You'll see it go down the coronaries, and then you see this little swirly, squirty guy squirting into the LV of contrast. That's at the Bayesian vein, or it could be one of these arterioluminal sinuses where the contrast, instead of going back down the vein and out of my picture, it's squirting into my LV, and I see these little contrast swirls in the LV. Like, what is that? That's what that is. And you'll see that when you guys go to clinical. Now you know what it is. It's an arterioluminal artery, or most doctors will just call it a Bayesian vein. Oh, there's a Bayesian vein. Okay. We don't get excited about it. It's just there. Okay. You know, some people have colors of eyes that are like Australian Shepherd dogs, blue and green. And then you see that, it's like, that's interesting. I don't see people with 2 different colored eyes very often. But there they are. Just like at the Bayesian vein. Don't see that every day, but I know what it is. Okay. And then there's these weird little like sinuses, these little cavities, and they're called sinusoidal cavities. The blood really doesn't, the LVs, think about this, the heart is sitting there. Like if you lose a coronary artery, you don't get any flow down the capillaries, your heart muscle dies, you got a heart attack. But how could that be? Look at right here in this LV is 98% saturated blood, and it's like your heart muscle is sitting there next to a big ocean of water of red oxygenated blood, but it's dying. It's like standing on the beach of a lake and dying of thirst because you can't get the water. But these little sinusoids are supposed to maybe be able to let a little bit of blood get from the chamber up into the tissues. Now, that doesn't happen very much for humans, but reptiles have this in spades, meaning a lot of it. So like reptiles can stay, like an alligator can stay underwater for like an hour waiting for the person to come get a drink or the golfer to go get his ball at the end of the pond. If you're golfing in Florida and you lose it in the water, leave it. That's what I would say. Because they wait for like splashiness on the edge of the shore. So the lizards, they have a lot of these, so they can actually take the oxygen from their blood and right into their muscle. And they also carry a lot of certain animals, like sea mammals, they carry a lot of oxygen in their muscles. It's called myoglobin. We'll get into that next week on the last video that you guys are going to watch on your own and just take the 1-question test. Next week, which says, I watched the video, it's worth 20 points. Yeah. And that'll get, because I won't be here to test you. So that'll be the last chapter, but it'll kind of get into some of that. Anyway, that's enough about that. For a while, I'll tell you this thing here. For a while, we tried to do this thing where we would burn laser holes in the heart to make these sinuses and then let the body, like for people that had such bad coronary disease, we couldn't put grafts because they had all these tiny little diseases. And we couldn't put grafts in because the arteries were so small. So we burn laser holes and we thought, okay, we'll make these little sinuses with these little laser holes. And then the heart will become like a reptile and it'll get its own drink of blood from the LV. And it's not like, yeah, that's a good idea. So somebody venture capitalists invested millions in this and it just failed completely. The people that had this done, they didn't feel pain with their ischemia anymore. And they thought, well, that's great. They don't feel pain anymore. But they were still having ischemia on the EKG. And so they like figured it out later. Well, we just burned all the nerves so they don't feel the pain anymore. And so like, this isn't good at all. So they stopped it. You'll never see this TMR, but for like 4 years, it was the big thing. It was like 15 years ago. It was a big thing. We're going to do the transmyocardial revascularization with the argon laser. We put this laser, burn all these little holes, and surgeons would do it, and it didn't work. We don't want to be lizards. We're not lizards. We can't be turned into lizards. So this is a slide that shows us about perfusion pressures to the coronary arteries. So the LV, just think about this. The LV is generating the pressure to the aorta. So when it constricts, it goes up to like 100, 120. But the pressure in the wall of the LV has to be at least 120. So if you've got a really tense wall and you're trying to put blood down into that wall while it's all tense, it doesn't happen. The perfusion, the gradient won't let it flow in there because the wall tension, the pressure in the wall itself is 100 because it's pushing blood out the aorta. So the wall itself is all, think if you like flex your biceps, how stiff it is. If you're trying to get blood to go in there, it doesn't want to go because there's a lot of tension there. So when the heart relaxes, that's when you get most of your coronary flow. The rest of your body gets a surge during systole. Like if you feel the pulse on your wrist, you get a big pulse. That's when your hand gets a surge of blood. Makes sense. The heart is kind of the opposite. When it's pumping the big surge to the body, it's under pressure, so it doesn't get a drink until it relaxes. And this is very pronounced. And this is a graph of the flow in the left coronary, and it's reduced during systole, but the left coronary gets a high flow in diastole. So the majority of coronary flow in the left coronary happens in diastole, which is kind of weird. That's something you'll learn about this chapter. The next slide will show us this graph. This is the aortic pressure. There's the left coronary flow, and this is mils per minute down the left coronary. And here's the right coronary. Look at the difference. What do you think about looking at those two? What do you notice between the left and the right coronary flow?
Are they left dominant?
Well, that's probably a left dominant. Oh, I see. You're thinking because the left has more flow. No, that I see what you're thinking on that. That's a good guess, but well, look, what the point I was trying to make was the right coronary kind of doesn't look different. It kind of looks like the aorta. But think of what the pressure in the RV is. It's only like 25. So the aorta is pushing 120. That can overcome the 25 that's in the wall of the right ventricle. So the right ventricle flow is really greater in systole because that aorta pushed it in there. Over 120 overcomes the 25 pressure in the wall of the RV. So the RV is not really affected so much. It doesn't get such a big diastolic surge, but the left does. That's the point I'm trying to make here. Okay. And that's just kind of saying the same thing. So we can measure coronary flow with the Doppler wire, and this is showing systolic and diastolic flow, and the diastolic flow is greater in the left coronary. This is just showing it with something called it's FFR or IFR, vascular flow. We actually, for you echo guys, we have like a 20 megahertz transducer on the tip of an 18,000th wire. We can push that down your coronary and measure Doppler flows in the different branches of the coronaries.
Wow, that's so cool.
And you guys have like 3 to 5 megahertz transducers on the chest to penetrate deep. We're at 20 megahertz because we don't need to penetrate. We're right there. Okay, we take advantage of this physiology, knowing that the LV gets more flow in diastole with a device called an intra-aortic balloon pump. When someone's having heart failure, their heart's not pumping enough to meet the need of the body, like cardiogenic shock. We put a balloon filled with helium and we block off most of your aortic flow and we time it so it's up in diastole, down in systole. And so this helium is used because it's number 2 on the periodic table. It's very light. It's what they put in those little balloons you get at the zoo and they float. Hydrogen is number 1 on the periodic table. It's even lighter than helium. That was what was in the Hindenburg. Remember what happened to the Hindenburg? We don't use hydrogen because it's flammable. Helium is not flammable. So we use helium in our balloons. We can suck it in and out real quick. So we put it up in diastole and we get this, we make the pressure of the proximal aorta stay high and it perfuses the brain and the coronaries. So that we divert the flow to the vital organs with this intra-aortic balloon in a cardiogenic shock crisis situation in the cath lab. We also have a little impeller pump we can put in your LV, and it sucks the blood out of your LV and pumps it into your aorta. Those cost $30,000. We use them once and throw them away. It's terrible waste. These cost about $600. We use them once and throw them away. The people that sell you the $40,000 pump will tell you how great it is and how much better it is. The people don't have to try too hard to sell the $600 pump because it's only $600, the balloon. But there's a lot of studies that going on, and you go back and forth when you look at the studies. Do I get more survival with my patient if I spend $30,000? The answer better be yes, and it's not always yes. So we'll see. That's called evidence-based medicine. We look at the evidence and make our decision based on that. Okay, enough about that. If you have a slow heart rate, you have a longer diastole, so that's good for you. You get more coronary flow. You have tachycardia, the heart's working hard, it's working fast, you don't get as long of time to fill. So that just kind of exacerbates ischemia. This one is a flow. This is exactly like the myogenic mechanism you saw last week or 2 weeks ago when we looked at the muscle flow in the arteries. If there's high flow, then there's constriction to bring the auto-regulation is to maintain a steady flow. If there's low pressure, then there's vasodilation to open them up and let more flow. So the heart wants its flow. So it wants to maintain a steady flow through different workloads. Now here's something about the heart. Almost all the flow that regulates the flow to the heart is done locally. The brain isn't involved very much. The heart controls its own destiny. So this myogenic mechanism, the heart is very powerful. The neural influence on flow to the coronaries is minimal. The heart is always in control of its own flow. The body, like when you're sleeping, your legs, your body will send flow to your legs as they need it. And the local is only going on when it's working, right? Remember that from that chapter? Local takes over, local at the muscle takes over when it's exercising. Well, the heart's always exercising, so local's always involved. The brain's not so involved in flow to the coronaries. Okay. That's what that says. Now, how does the heart regulate its own flow? That's the question. Well, there's neural interventions, but the local will take over. And how does it take over? With nitric oxide. And that is this, when the endothelium doesn't get the flow that it wants, then it's going to release vasodilators and open the arteries and let more flow go in. Because remember Pustilli's law, if I double an artery, I get 2 to the 4th, I get 16 times more flow. That's a really powerful regulator of flows, vessel diameter. So nitrates to relax the media, it comes from the endothelium, but it affects the media, which is the muscles, and they dilate. Make sense? Okay. There's about 5 slides that talk about this same thing. Here's the local coronary flow regulation, and this is saying myocardial oxygen consumption, coronary blood flow. So this is a graph that's linear. It's almost 1. That's just what I already said. The heart controls its own flow. All these dots were study points. They had different study points of an animal. Okay. So the coronary blood supply needs to meet the demand. Have you guys ever been on a run where you're out exercising and you have lactic acid buildup and you have achy muscle the next day? That's because you went into oxygen debt in that muscle. You can't do that in your heart or you have ischemia and cell death. So the supply has to meet the demand. You can't you can't have an oxygen debt in your heart without consequence like death of muscle. Your leg will just hurt the next day. Your heart you will have exploded some cells. It's like a Ferrari engine. It has to have its flow. Okay, that's what this all says. This is more about the vasodilators. Did we talk about this in another chapter about? We did. On the arterial chapter, we talked about when there's pressure or velocity, the heart will auto-regulate. This is going on, myogenic mechanism from that chapter. Same thing in the heart. Okay? So adenosine is a vasodilator, also available. Let's see. When you have vascular disease, the endothelium is disrupted, and your local metabolic regulation of this release of nitric oxide is inhibited. So with plaque, it disrupts the ability of the cells to release this nice vasodilator. Let's see what I get down here. You guys remember the plaque development where the LDL is the bad stuff? It crosses, it oxidizes, white blood cells are activated because of this oxidation. They become foam cells, they soak up They soak up the lipids. Now you have a lipid pool. If the cap of your plaque is thin, you're at risk. That's a thin fibrous cap. If you have a thick fibrous cap over your plaque, it's a stable plaque. You probably won't have a heart attack with it. You'll just get progressively worse angina, and you'll have time to come in and see us. And then when these smooth muscle cells, they hear all this chemical activity, they get involved, like, hey, I got to come and help out. And then when they die, they leave calcium behind. So that's part of why these old lesions are calcified. And you can actually see them on x-ray. They look like little bony outlines of the arteries. And if you feel them, they'll be crunchy. Hardening of the arteries was described by pathologists like 100 years ago. And that's the crunchiness of the calcium. Miranda has a question or a comment.
Under like fluoroscopy, is the plaque, if it's hard, is it gonna be like a lighter color, and then if it's soft, it'll be a darker color, or is that incorrect?
So you're right. So it'll be a density difference. And we can set our fluoroscope to different polarities, white on black or black on white.
Okay.
So if the bones are white, then the calcium will be white. If
Okay.
the bones are dark, the calcium will be dark.
Thank you.
But we usually set it so bones are, well, it could be set either way.
Okay. So usually the same color as.
Bones are
the
usually dark.
plaque.
So plaque is usually dark.
Okay,
Yeah, bones are usually dark, but we can invert those.
okay,
It's just a flipping of a switch of the processing of the image, white on black, black on white.
okay. Thank you.
But you can see they're the same color as the bones because
Okay.
calcium is in bones.
Okay.
Yeah, and they're like it's like a little cast of the artery. You can see the artery before you even inject contrast. That's not good. And then when we go in and try to put a balloon in there or a stent, it doesn't want to crack that calcium shell. So we go in with like a diamond cutter, the rotablator, and grind that calcium out of there. That's when we use a rotablator, is when there's calcified resistant lesions and we couldn't get the artery to crack. We'll just grind it with a diamond burr at like 200,000 RPM. Sounds like a dentist drill. Whee! That's what it sounds like. You've all heard that sound like,
Yeah.
I don't like that sound. If you don't have insurance, it's expensive. And even if you do have insurance, it can be expensive. Yeah, I've had, I told you my dental issues. There are some more plaques. When it starts off as fatty streaks, they did autopsies on kids in Vietnam, and they started finding fatty streaks at age 18. It's like, well, wow, this starts early. But it can be managed by your diet and exercise. Here's a cross section of plaques. These are the open lumens. There's layers of lipids. Then there was a tear in the artery and a clot formed. Then the body put a new layer over it and sealed it. And it just keeps building. Now this artery stretches out. That was that Glagov's remodeling trying to compensate. But eventually the lumen becomes compromised. And usually at about 50% obstruction, we start having symptoms of ischemia. If the plaque tears, then we could get clot and go from open to close in seconds, and then you have STEMI. Okay, we talked about that in the heart attack class. This is a cross section of, I probably already showed you, there's a torn plaque and there's a clot. Black is old, red is new clot. I won't go into that too much. Here's something that's new, and I'm going to try to get time is running short for you guys that have a 9:30 class. So myocardial oxygen consumption. Pressure work is more costly than volume work. So the LV uses more oxygen per liter that it pumps than the RV does. The RV's pumping to 25. It's pumping volume. The RV doesn't need that much oxygen. The LV is pumping at 125. It needs gas. It needs oxygen. Make sense? Okay. So myocardial oxygen extraction. What's the normal saturation of blood in your arteries? What's the color? The bright red blood, if I run it through an oximeter, we talked about this in hemodynamics, 98. Yeah, 98. And the venous blood that's in the veins, the purple, on your coming back to your IVC, remember the numbers we were using on shunts in our hemo class last quarter? In the 70s. So, went from 95 to 75. Well, the heart sucks the oxygen out of the blood because it's really hungry. It takes it down to 40. It sucks from 95 down to 40. It takes like a lot of oxygen. And the color of the oxygen, the color of the blood in your coronary sinus is black. I've pulled some out of there before in cases, and you get this black syringe, like, what? black blood? And then that's coronary sinus, 40, and you're running the oximeter 40% sat. There's just no reserve. Remember we were saying the supply needs to meet the demand? You can't have like oxygen debt in the heart, so the heart just sucks the blood, sucks the oxygen right off of it. It's really thirsty for oxygen. And if you don't get it, you get an MI, and these next few slides talk about that. So I'm not going to get into the MI stuff with you guys. We already addressed that in the heart attack class. But this is what a sub-endo MI would look like. The coronary arteries feed here, and they come down, and this part gets the last blood. And so it dies first. It's weird that your heart, I already said it, but your like LV's 98% sat, and the tissue sitting right next to is like standing on the beach of a lake and dying of thirst. But that's where we tried to make ourselves lizard hearts. This wouldn't happen to a lizard, but the TMR failed. So that's called a subendo MI. And then let's see, I don't have a good picture of a transmural MI, but it would be all the way through the wall. Okay, and you know about that. Now, if you keep getting exposed to ischemia, your body will develop, it will release something called vascular endothelial growth factor, VEGF, and it makes its own new arteries, and it makes collaterals. So it builds its own bypass through the back door, okay? And not everybody can do this. You have to have a repeated exposure to ischemia over a period of time, and then the body can develop that. But if you went from an open artery to that torn plaque and clot and it just shuts off, it takes time, and you're not going to get collaterals if you have an immediate, like seconds, a clot form, shut it off your artery, that's it, no collaterals, you're going to lose a lot of muscle. So that's what collaterals are. Go ahead, question?
So for the vascular endothelial growth factor, is that something that helps those collaterals open up?
That's what makes them grow. That's like the grow juice. That's like the miracle grow. That's like this fertilizer on the arteries to make them grow.
As well as like the pressure from the...
Yeah, pressure sensors will say I'm ischemic. There's a lot going on, and the body's releasing nitric oxide to try to let more flow, but
So it's just kind of like one of those factors that helps the collaterals open up.
that is, they identify that as
That's
what,
like the
that's
main
like the
thing.
miracle grow for the
Okay.
garden. That's what makes the collaterals grow. VEGF. Now, if there's something called, there's two terms that I thought we had a slide. Have you guys heard the term stunned or hibernating myocardium? I want to introduce this. You heard it?
No, I have a question about the collaterals.
Okay,
I'm
collateral
sorry.
question.
The collaterals, say it's coming from your left going towards your right, is that it's shunting the blood from your arterial system to your venous system? Am I incorrect?
Well, the end of the capillary, so no, it's kind of not going through the venous system. It makes its own pathways.
Okay.
So it makes an arterial to arterial connection.
Okay.
So you get down to the tiny little arteries, and the little arteries reach out and connect to each other like little roots.
Okay, that makes more sense.
It's not using the venous system. It's artery to artery, but it's new
Okay,
new-
yes.
new
It's trying to
tissue.
get that new blood supply. It's trying to get that new perfusion.
Yes.
So that's
So
why
it's
the
going to go
collaterals-
backwards. It's going to go through an open artery, and then this is a dead zone. It's going to go back through the dead zone and reconnect to those arteries that were occluded and reperfuse them
Okay,
on the other side of the clot that was stopping the flow.
Okay.
So it comes in back, or not the clot, but the plaque.
yeah, that makes sense.
Yeah.
Its own bypass?
It
Yeah.
builds its own bypass.
Yeah.
Okay. Now, if you keep getting exposed to ischemia, your heart will do something to protect itself. It does something it's called hibernation. If you keep putting the heart in ischemic mode, it'll actually down-regulate its ability. It'll turn down its horsepower, and it won't work as hard, but it'll save itself from killing itself. Like it will down-regulate its energy output, so you're not going to be able to generate as good a blood pressure, but it won't create the MI as quickly. And that's called hibernation. The heart kind of like slows down like the bears do in winter. They go to sleep because they just stop using energy, and they can survive on their fat for the rest of the winter. And your heart can do that. It's called hibernation. And so sometimes after a heart attack, we look at the wall motion, it's not moving. And we say, wow, they lost their wall. 2 weeks later, we come back, we reperfuse them, and the wall's moving. You're like, hey, how can a dead wall come back alive? Because they don't. It wasn't dead, it was stunned. It was stunned or it was hibernating. Stunned is more of an acute event. Hibernating is a chronic event. So if you create ischemia, the heart stops moving right away, that's called stunned. But if you keep exposing it to ischemia a long time and it goes down regulate for a long time, like a bear in winter, that's called hibernating. So there's two terms where the heart can actually down regulate the energy that it uses to protect itself. That's called stunned or hibernating. Go ahead.
Is that sustainable though? Like.
Not really,
Yeah,
but it's just a protection. It's a compromise. And it can't go on forever, but it's like a protection mechanism. Okay, and that's kind of the last. We use bypasses or stents when people have plaques, and there's what a plaque looks like, and then that's nothing new. There's a transmural MI and there's a subendo, but that was really what I wanted to tell you guys. And time is important to not run long, so I will stop there. All right.
It was nice having you in person.
Good.
We're gonna hold you hostage.
It was nice having this class with you guys for echo and vascular. This is the last class I'll have with you guys live.